A very good afternoon, everyone. Thank you for joining in to listen to a topic that everybody is wondering what it is all about. Right? The topic looks we have not heard of this before. So my objective here is to yeah. So my objective here is to walk you through this particular topic. Okay, just walk you through, not to go into details, just to inform you, make you aware of something like this exists, and maybe in the future, when we hear about this, you already know what it is. So to start off this topic, my objective is to present this topic in such a way that I tell you all about it, and you'll not realize I've already told you all about it. Okay, so with this objective, let us start. Let us start with a scenario. Yes. Is it? Okay. Yeah. Okay. I mean, I just use this one. Okay. So let's start with the case scenario. Okay. Um, have a look at this one. A 34-year-old patient reports to the dental clinic with pain in the lower left back tooth because of a big cavity. Would you all agree that this is a common complaint among those who are attending for dental care? Yeah, pain and cavities, correct? So when you see a patient who comes into your clinic and says this, the question that comes to mind is, how are we going to manage this case? Correct? So if I ask you, how are you going to manage this case? We have to go through a number of steps. Correct? So can anybody tell me what would be the first step in management of this case? Case history, right? So we have to do examination diagnosis. Now, this particular step of examination diagnosis is not one step. It also has multiple steps within it, correct? So we have case histories, we have intraoral, extraoral examinations, how to take a radiograph, pulp testing, finally linking all the dots, coming to a diagnosis, and from there go on to have a treatment plan. So if you see, this particular step has sub-steps, and if you really want to do these sub-steps properly, you really have to be competent. Do you agree with me? So do we have a competency for case history? Yeah, we have a competency for case history. Do we have competency for radiographs? Correct. So you see, you need to have multiple competencies in order to have a good examination and diagnosis, right? So let's go on to little more complex situations. So after we have done everything, we need to do the treatment. Now, this tooth with a big hole, it can have multiple treatment modalities, right? But some of common ones would be, you have to give an inferior alveolar nerve block, all right? Then you have to go for an extraction, or you have to go for an RCT. If you're going for RCT, you have to go for a crown. If nothing is possible, you have to go for an extraction and followed by prosthetic replacement, correct? So would you again agree with me that all of these mini sub steps are competencies by themselves? Do we have a competency for inferior alveolar nerve block? Right? Do we have competency for restorations, ICRAS 0305? Do we have competency for RCT, right? So you will agree with me that all these have competencies, right? We go on further, we treat the case, and then we have to review the case. In the review of the case, you have to look for success of the case or failure of the case. You need to recognize the signs of failures, right? Again, you need to be competent. You need to maybe take a few radiographs again, do a clinical examination. So you basically have to be competent in review of a case. And finally, if there is an alternate treatment plan, you have to go ahead and do that, right? And the last step would be the closing of this whole loop will be the maintenance, right? Where you have to start off with preventive dental care so that this problem does not reoccur in other teeth, right? So can you give me one example of a preventive dental care? Fluoride application. So in PETS, fluoride application is a competency by itself, right? Can do that procedure and they can be tested for competency. So you will see that all these 5 steps, they have a definite beginning and a definite end, right? And all these have mini competencies within it. So if you imagine a graduate, right, who has to do all this, he has to be competent among all these areas, correct? All right. So with that thought, let's go ahead and imagine if this particular case has come to your dental clinic. All right. You are the supervising dentist and the case has come. The first question that is going to come to your mind is, how are you going to assign this case to the trainees? We have a lot of trainees, correct? So how are you going to assign this case to a trainee? So there has to be, you're thinking about that. Have you ever thought, if the case comes, who are you going to give the case? Normally we have the list, and according to the list we go, correct? Now we have that list because we already know that all the trainees have achieved a level of competency. Now when we say competency, it is KSA, knowledge, skill, and attitude. Okay, and now experience, right? So when year 4 joins my clinic, I already know his competency level is at certain level, right? Certain things he can do, certain things he cannot do. So when I'm allotting the case, I look at the competency, correct? So now imagine you have already given this case to a particular student. So the show doesn't end there. You also have to ask yourself what kind of close supervision the student would require, correct? So student may require very close supervision, or he may not require any supervision, or you may just say, I cannot give this case to him, correct? Has it happened to you that a case has come and you said, oh, please, you don't do this, let me give it to somebody else because you're still not competent? Has it happened? So your supervision can range from not allow the case to give a case to a student to manage independently, right? Like how I do in PEDS, maybe a scaling for an older patient, 14-year-old, 15-year-old, I just give it to the students and just come and check. In the end, the students independently does it. So this is how the thought process goes, correct? Now, so if this case has come into the clinic and you're looking at the competencies, right? So some broad domains of competencies you must have, right, in order to ensure that the student is competent. So for me, I just have made my competency domains as knowledge. The student must have knowledge of tooth anatomy, morphology, pulp morphology, periodontal structures, pulp pathologies, what medication, because the patient is in pain, you're giving LA. So the student must be able to recognize all these things, correct? So would you agree that the student should be competent in having all this information and recognizing, right? Then we have skills. So the students not only should have knowledge, but should have all these skills, correct? Then only I'll be confident to give the case to the students, right? He should know how to gather proper case history, how to do a root canal, how to write a prescription, how to do an extraction. All right. So third one is your attitude. The student must also have an attitude which is in line with the professional guidelines. So empathetic, being professionalism, having conscience to refer the case if he's not able to manage it, confidence and communication skills. So now this patient has come to my clinic and I'm the supervisor. Now I'm looking at all these domains for my student and deciding if he can do it or not. So maybe he knows everything, but he has not practiced all of this. So he doesn't have an experience, or he may have an experience. Okay. So to manage this case, when I'm selecting a student, I have some competency domains. Okay. For example, case history itself will have domains in itself, right? So just brainstorming, if my case history is my competency, what mini domains are you going to look into? Correct? Have you done your case history competencies, right, for the students? Right? In GED we do, in OMR we do. So we have sub competencies. For example, in perio scaling, we have sub competencies. We check things, checklist, right? All right. So these are the competencies. Now, once you allocate this, you also need to supervise, correct? Now, supervision is based on these 4 factors. Okay. How is the trainee, right? How is his attributes? Is he tired? Is he confident? Is his level of training? Okay. Or the attributes of supervisors, whether supervisor is lenient or strict, right? Supervisor is one of those who takes the risk, kind of thing. Then the context is beginning of the day, end of the day, right? And what facilities are available. So when you're managing supervision, all these things come into the picture. And finally, nature of the case. If it is a rare case, or is a complex case, or is a common case, or easy case. Easy case is good, you can give it to anybody, but you still have to supervise. So if you look at the supervision, either you do not allow the case to the student, cannot do, sorry, or you have to have a proactive supervision. That means you have to stay with the student and walk him through all the steps. So this is proactive. Maybe you're assisting the student, or maybe you are standing there and looking at all the steps he does, That is one supervision called as proactive. Next supervision is the reactive supervision. That means you need not stand there, but you are available when the students needs you. Okay, so student is doing a deep cavity, he exposes the pulp, he calls you, and then you come in and you manage it. So this is reactive supervision. Or the patient undergoes syncope and you call the supervisor. Reactive. And finally, no supervision required, right? You can independently give the case to the students to manage from the start to the end. That means case history, E&D, he starts with the case gathering of the history and ends with a treatment plan, right? So no supervision required. You trust him. So in reactive supervision, you still double check everything. All right. And of course, in proactive supervision, everything is right under your nose, everything that is happening, right? So these are kind of supervisions that we normally do. Now, would you agree with me if I say from your clinical experience that we have some students who are competent from the simulation exercises, but when you give a case to them, they get scared. They're not able to handle it. Has it happened to us? Correct? Right. Has it also happened that a student who was scared initially has done a few cases and you give him a complex case, a little more complex, and he gets scared again? Is it possible? So we have realized that there is a possibility of a gap between being competent and being able to handle cases in clinical practice, right? When you have to do independently. Okay, so there is this gap that was recognized. A lot of students are competent. Oh, inferior alveolar nerve block, awesome, can give. But it comes to something like extraction of firm molars, superb intra-alveolar nerve block, everything is good, luxation good, everything good. But once the student is given an extraction of a firm molar, in a hypertensive case, the students get scared, right? And then suddenly they're worried how to manage it. Correct? So this is the gap between competency and managing clinical cases. So the question arose, why not assess a trainee by giving them a clinical task where they must combine different competencies to achieve a desired outcome? All right, a typical example here is you taking case histories. Okay, so in the case history, the whole E&D is a procedure. The whole E&D is a procedure which has multiple competencies: how to take a radiograph, how to do a pulp testing, how to gather history, how to arrive at a diagnosis, how to plan a treatment plan. So this is all history. So this becomes your task. Okay, task of E&D, which has multiple competencies. So now this was realized that this is what we need in a graduate. A graduate must go out and he must have these competencies, use multiple competencies for a scenario. And this is where the entrustable professional activities was realized. Right? Now, what these activities are basically these tasks which have multiple competencies you must have to perform it. Okay, so these are units of professional practice that must be entrusted to a learner to execute unsupervised once he has demonstrated the required competence. And this bridges the gap, and it can be a simple task as clerking a new patient, or it can be a complex task as in extraction of firm molars in a hypertensive case. Okay, now just to check if you are on the same page as me, when you say extraction of a firm molar in an hypertensive patient, what are the different competencies the student must have to manage this case independently under reactive supervision? Okay, can we just name a few competencies? He must be competent in nerve block. Awesome. He must be competent in extraction itself. He must be competent in prescription, management of adverse effect, because he is a hypertensive patient. He must be confident in recognizing medical emergencies, correct? Not only recognizing, but acting upon it. So you see, the whole thing now becomes an entrustable professional activity. So now, if somebody I can trust to give this patient, okay, now I'm asking all of you, we have faced these kind of situations in our own clinic where the things are a little complex. Whom do you trust among all the students that you have? There must be some you can trust immediately. You can just give it to him and you tell him you manage. When you finish, you call me. Has it happened? Say, for example, plaque control. periodontitis, deep pockets. Has it happened that you gave this patient to, say, somebody X, and you say, okay, please manage this case, okay, and tell me about this case tomorrow. What has happened? What, right? Has it happened to you? Has it happened to others? So we have an spectrum, some yes, some no. That is how the training starts. So these are some of the entrustable professional activities that has been, suggested. For example, management of a child who has sustained dental trauma. From beginning to the end of management of trauma is whole big activity. Okay. Then delivery of oral health education to pregnant women. So you see, these are all individualized tasks. It's not a very broad task. So the question arises, how individualized or how broad should be an entrustable professional activity be? So we have a framework, all right? So in this framework, we start off with the health outcomes, right? From that health outcomes, we have to see what kind of EPA we can plan. And you will see from the EPAs should satisfy the competency domains. And these competency domains themselves must have KSA. All right. So this is how. So let me give you an example. So my health outcome is practice universal infection control. Would you agree that every graduate must follow universal infection control when they graduate? Okay. So what I did, okay, now this is a broad topic, right? So I pick up management of needle stick injury. Management needle stick injury. Is it important? Yeah. Is it essential or not essential? It's essential, right? So how to manage? So now my competencies that I have started off, that wound care is my first competency. The student must be competent in the wound care. So to do this competency, he must know the risk factors of infective diseases. And then he must know the guidelines for the wound care, to squeeze or not to squeeze, to wash it under the running water, to put it in alcohol, what to do, right? And of course, how to do. So this is my competency number one, and these are my sub competencies. My next competency would be how to manage patient handoff, right? In this patient handoff basically means how to transfer the patient. The student needs to know all the documentations and how to fill up. Okay, if I remember, one of our OSCEs we did was needle stick injury where they had to fill up a form. Do we remember that OSCE? Correct? So just imagine that was OSCE in a simulated environment, in a controlled environment. Same thing happened in the clinical practice. So I'm sure those students who have passed this OSCE will not be able to manage this one when they're faced, or they may not, maybe, depending on the test. So we create a EPA for this one in the clinic. So we don't create, we just have to have a EPA that this must do before you graduate. Then, of course, you have the necessary tests, knowledge of all the necessary tests, how they are done, where it is done, what the report look like. Then professionalism in that effective communication to the patient, and then the teamwork that is involved in managing the patient. So this is how, if an EPA has to be formulated, this is how we will formulate. This is the framework. So when you frame the EPAs, we manage the EPA. For this EPA is from Saudi Medical Council. So their medical graduates must have these 8 EPAs. And these 8 EPAs will have multiple competencies. So the competencies are patient care, scientific approach, research scholarship, professionalism, communication, collaboration, and community-oriented practice. So any graduate must have all these competencies and he must perform all these EPAs. So you will see that each EPA has multiple competencies within it. It's just not one competency. So this is an example of mapping of EPA to competencies. So now the question comes, how many EPAs should we have, right? So this EPAs in undergraduate education has just started. I mean, first EPA was introduced in 2005 mainly for postgraduate, because they really wanted to ensure that they're safe to practice. But now it is coming to undergraduate. So now here in this particular school at University of North Carolina, they have 4 EPAs for a graduate must complete before they graduate. And these EPAs will have subsequent competencies within it. So it's a very good one. If you can go to this website, open and click on all these EPAs, you will have a lot of rubrics how to measure each of these competencies. All right. So what now I try to tell you is that in the chart, in the graph that you see on the left, we have how many EPAs there? 5. Now, EPA The green one, they started on the day one of the training, okay? But this was the fastest EPA that the student was able to complete, right? And this competency threshold is the time when a decision was taken to leave the patient with the student to complete the case by themselves. So the green one, the EPA 4 achieved very fast and it remained on high competency level as compared to the red one. Though it started first, I mean, in the initial days of the training, the achievement of EPA to the threshold that can be given to the student only happened at the end of the training. And from the end of the training, when this student has not performed the EPA enough, that we have now lost his competency in the EPA that he cannot perform anymore, right? So EPAs can have a number of EPAs you must do in order to ensure that the competency level remains high. So number of EPAs we still have not decided, right? A lot of research is still going on how much we should have, how many we should have for undergraduate. So when we talk about level of supervision, right, there are 5 levels of supervision, like I already told you. Okay, can you just tell me what are those? One is don't give the case at all, right? Next one is proactive. Next one is reactive. Fourth one is independent, right? And the fifth one is that actually that person can supervise others who are doing EPAs. So these are the levels of supervisions. Like in this level of supervision, the simpler form is on your left side. The more detailed form is on your right side. So for example, a student who is an undergraduate must have EPA level of supervision 3. That means it is allowed to practice EPA only under reactive supervision or supervisory request with an immediate accessible supervision, and all findings and discussions have to be double checked with an immediately accessible supervisor, and key finding decisions have been double checked with supervisor at a distance, maybe on a phone call. The findings and decisions have been promptly reviewed. So any of these, right? For the postgraduate, right? What would you suggest should be the EPA scale for a postgraduate student? 4. Okay, 5, he becomes a faculty already. All right, so 5. So 3 for undergraduates, 5 for postgraduate, 4 for postgraduate. Okay, 4. That means they can do it without supervision, with a distant monitoring, and or without monitoring. Right. Right. So now the question comes how to give the case to the students. So you have to make a decision. This decision is called as entrustable decision. Entrusting the students to perform whatever the task that you're giving, right? Efficiently, effectively, and safely. So this task can be ad hoc, right? So these are the same what we have discussed earlier. Perception of the student's characteristic, tired, not tired, level of training, the propensity of the supervisor to delegate work. Can he delegate work properly or not? Complexity of the EPA, rare case, simple case, easy case, context. What is happening? The student is learning extraction. You cannot give him a competent EPA for root canal treatment, right? It has to be in the context of his learning. And the nature of student-teacher relationship. What kind of relationship are we talking about here? Student-teacher relationship? Trust. Trust, honesty, integrity, transparency, right? Or this is one way. So this is ad hoc. The patient comes, you assign the patient to the student, and then you follow him up. Or now for postgraduate training, we have something called as summative or statement of award of responsibility. So these are like our OSCEs, but actually on actual patient. Okay. So those who have graduated in 1990s, if you remember, in conservative university exam for BDS, in BDS, when I was giving my conservative dentistry exam, I had to do a class 2 cavity preparation on an actual patient, right? On an actual patient. How many of you have done that? All right. So that was your summative EPA. Summative EPA from injection of LA to the class 2 prep. Then you will expose the pulp. Then what do? Huh? You fail. Correct? Right? So, correct? So, so similarly, we had it for extraction also. Okay. They still, okay. So yeah. So in order for the student to reach that level where he can be assessed, there must be multiple observers who are doing multiple observations, where they're doing several case-based discussions, product evaluation, knowledge and skill assessment, and the student has a rigorous scores and activities. Then only he can go ahead and do this summative statement of award responsibility. So basically, this is the last one. It's fit to practice. Okay. Now this EPA can be simple EPA or complex EPA depending on the year of study. So that is how you make a decision. So now when you're creating an EPA, right? So these is the suggested titles. So you should have a title of the EPA. Then in that EPA, you must have a specification. So specification limitation, that means what students is expected to do and what things he's not expected to do. What is the limitation? Then potential risk of failures, right? Imagine we are doing an EPA for needle stick injury, right? So is there a potential of risk of failure if he doesn't perform the EPA properly? Correct, right? He may get infected. So this risk we must identify right in the beginning. Then association with the relevant competency scale. What is his competency scale? What should he achieve? Knowledge, skills, attitudes, and experience in managing in general. Source of information to support the entrustment decision. So you're entrusting the student with a case. What source of information the student already has? And then finally, expected level of supervision for this EPA in the educational program. So in our educational program, what is the level of supervision that is required? It depends upon the procedure. But for us, your 3 is the one, right? The 3 is baseline, must have competencies. The suggested is must have 3. Right? And then period of expiry. So if you do needle stick injury EPA today, it will expire when you are in year 5. That means in year 5, you need to do this EPA again. And that is how your competency curve, remember the red one, will go up initially. In the practice, it will come down. So this is how it is designed and written down. We call it as a descriptor. So this is more in detail of how these descriptors should be. So we will not go into more detail because once we are actually trying to write a descriptor for EPA, will go into more details. But I just want you to remember that the description, for example, just pick description to enhance universal clarity, include everything necessary to specify the following: what is included, what is the limitation apply, limit the description to the actual activity, avoid justification of why EPAs is important, reference to knowledge and skills. So it has to be very, very objective, very, very clear cut, right? So required knowledge, skill, and attitudes, which knowledge, skill, and attitudes are necessary to execute the EPA, formulate this in a way to set expectations. Of course, refer to the sources, right? So we're not going into details, but this is how it is done. These are all the titles, these are the headings that we have. So we do not have much examples on the internet for EPAs in undergraduate practice, right? Most of them are paid articles, but I was able to pick out one where they're doing EPA for information gathering in for a dental graduate working in an army hospital. Okay, so here if you see the competency levels, they have already decided clinical cognitive. They already have Pakistan Medical Dental Council. They have their own competency levels. Do we have in Malaysia for Malaysian graduates what competencies they should know or have? Yes, correct. So we have for Malaysian graduate must have what competency. So those are our fundamentals from where we pick up and then we formulate. Then we have sub competencies, collect the record, clues from the patient and relate history to oral and systemic condition with the current situation, select and interpret specific and general investigations, identify common diseases, differentiate between normal and abnormal features, etc., etc. So this is an example of an EPA. So this EPA, because of its rigorous assessment we have this has been classified as the topmost assessment method. Can you remember what is this triangle called as? Anybody can remember this triangle is called as something? Miller's clinical assessment. Okay, so the Miller said fact gathering is the least important, so it's nicely portrayed in the picture. So basically, the student writes an MCQ test, right? Goes on next level where she does a case presentation or she does a case discussion where she talks about how to do a lumbar puncture, describes the steps. Then she goes ahead and demonstration of learning where she does it on a simulation, right? That is via simulation and OSCE. And then finally, she goes into the ward and actually performs a procedure on a patient, which becomes performance integrated into practice. And this is typical through direct observations and what is called as workplace based assessment. Okay. So the cases the students are doing in the clinic, right? If you look at in one way, it is actually direct observation or workplace based assessment. Only thing is that we're not rigorously assessing them. We start rigorously assessing them, we need to have some EPAs for it. Okay, so the EPA is the topmost assessment method in the Miller's triangle. So to wrap up things, what are the benefits and the challenges of EPA? So if we ask you what are the benefits of EPA, can anybody just top of the head tell me what would be the advantage of having an EPA for student training? Can identify the good students, can. And how you do that is basically when you standardize practices of assessment. So you clear cut knows who are the good ones, who are the bad one, because we have a good standard of assessment practice. We have improved alignment to the professional standards, right? Whatever the Malaysian Council is saying about competencies, we are achieving it or not. And in hand focus on practical skill development. Okay, so what is that hands-on in the workplace becomes very, very important. Challenges. Any challenges do you find that this EPAs would be in terms of implementing? Too much work for the staff. So we have faculty development and training is a challenge. Okay. And some of the literatures have actually said the resistance from the faculty is a challenge, right? So that is why faculty development and training and of course, allocation of assessment for the robust assessment methods, we need more number of cubicles, more number of space, those particular patients that we need for the EPA. So it becomes resource intensive. And of course, the potential need for curriculum revision, right? So this nobody wants. All right. But to summarize, the EPAs are here because they are important and it's recognized to bridge the gap between competency and clinical practice. So they are here to stay, right? Now, in undergraduate curriculum, more and more research is going on and they're coming up with a lot of EPAs developing by a Delphi method, right? So we just sit down and decide, okay, pediatric dentistry, we must introduce 3 EPAs. Then all of us will sit together and we will discuss and we'll come out with the health outcome and the task. Okay, and then the domain, and then what knowledge is required for the domain. So yeah, we can do that. And people have started talking of a shift from competency-based curriculum to an EPA-based curriculum. So in the future, this is incoming, right? So in that EPA curriculum, we will not have any competencies anymore. It will be like all EPAs. So how they're doing it in the Western and the Europe is that during your graduation, they said there are some 25 EPAs that you must complete satisfactorily. That means at the level 3 supervision, right? For the summatives, you have 7 EPAs to your first your summative. And then only you can graduate. So that is how your EPA-based curriculum is now being designed and may come in the future. So the development of EPA, implementation and assessment strategies is a story for another day, right? So yeah. Okay. So that is how it is. So too early for us, right? So yeah, these are the things that I read. And of course, thank you so much for your attention. So yeah, Dr. Ajay is also on it. Dr. Jaya is also on it. Dr. Guru is also on it. So they have also been reading along with me. So anything you want to add? Yeah. Yeah. Yes. Mm. So like you said, these are all students' attribute. Okay, but EPA is a task-based activity where different attributes have to come together and assessed as a whole. So that is your EPA. Yeah. EPA. For example, I can give, we have root canal treatment, correct? Students are doing anterior treatment, premolars and everything. You can create an EPA by having an endoperio problem. Correct. So this task, again, you have to sit together and decide based on the national competencies. So that is our shortcoming, that we do not have enough cases. And when we sit to decide an EPA, these are the things that has to be discussed and ruled out and ironed out, putting some limitations, specifications to have to develop an EPA. So it's just cannot have, ad hoc. We just cannot have an ad hoc EPA. Yeah. Yeah. So, mm. So I just used an example of endoperio problem. So here we have multiple competencies that can be measured in the same patient: management of endodontic pathology, management of periodontal pathology. Management of periodontal pathology can include from root planing, deep scaling, or correct flap surgery. Endodontic can manage from hemisection, right? RCT, correct? So you will see it's got multiple competencies. So it's a brainstorming we can do how this becomes a EPA. Now this EPA, not every students may get, correct? So that is why number of EPAs needs to be decided. So we are still in dental curriculum not decided how many we should have. So some of the universities in Netherlands who are doing it, they say about 24 to 34 EPAs from year 1 to year 5 they must have. But they have not mentioned what kind of EPAs or specific EPAs. They have suggested a few lists, what I've shared with you. So we have to still develop depending on our local scenario. So these, what I've read, there's certain EPAs which are elective and certain EPAs which are essential, right? So elective EPAs are those like needle stick injury you may not get, right? But essential EPAs are something like management of prosthetic replacement of a missing tooth. We used to start from scratch and end the case. So management of trauma, right? No, that depends. That EPA is of what value? Is it an ad hoc entrustable decision or it's a summative one? So if it's a summative one, then that summative one must be ensured that students already done a number of EPAs to entrust that. No, we are doing in FD. We have comprehensive cases. Actually, those are all EPAs, but we have not written the descriptor for those EPAs, and those are just broad EPAs. It could be anything, right? But yes, the mini EPAs assessment we're already doing when you're doing a comprehensive case, scaling, restoration, and at least must have 2 or 3 things to do. So yeah, we are almost there, but it's only the matter of putting version 2 EPAs. we can actually improve on what we have and convert it into an actual EPAs. No, because knowledge and skills we must assess before we can entrust the case to the student. Mm. 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 And that is how they have framed it, because for end up they say must do this case, this case, this case. No, we have level 1 students also. We have level 1 students. Okay, so any more questions? So just last question from my side. Have I been successful in my objective of introducing this topic to you in a manner that you automatically knew about it without having to stress yourself? Okay. All right. Okay. Okay. All right. Thank you so much.